But let's start discussion a little bit about these risk factors for the transformation. Many of these risk factors overlap to great extent to risk factors that are accounted for in prognostication of overall survival of the patients. And the prognostication for overall survival primarily is used to define the patients that would be going to a transplant as a consult if they have a life expectancy of less than 5 years. It seems to me that there is a good case to prognosticate for transformation to acute myeloid leukemia, but it doesn't really appear that we can do much about it, actually. Andrew, what do you think about that? Is there a real need for everyday practice to prognosticate not only for survival, but also for acute myeloid leukemia risk?
Yeah, I think so. And I think that certainly if we were able to identify patients who in the chronic phase were at high risk of transformation to acute leukemia, those would be the patients we would rapidly take to transplant to see if we could prevent that. Because, as Prithvi discussed, once the transformation occurs, it's really, really challenging to get those patients back to a state of their disease that's then transplantable with any kind of success rate. So I think that it's important to kind of take that into account, and certainly, our prognostic models in myelofibrosis specifically, look at overall survival, but certainly some of those risk factors that we include in prognostic models, kind of exert their impact on overall survival by increasing the risk of transformation. And we touched on some of those like thrombocythemia, cytogenetic abnormalities, and certain mutations as well. So I think it is important to do that.
Now, Prithvi, in ET and PV, you showed that at the beginning, that risk of acute myeloid leukemia is very small, but it is not trivial. I mean, for some patients, obviously, that will happen. And while we focus so much on the thrombotic risk assessment, we don't really talk much about the prognostication in terms of transformation to myelofibrosis or acute myeloid leukemia in ET and PV. Should we start doing that?
Serge, I think the problem with it is that, again, in the absence of a therapy that's going to retard or delay or prevent that from happening, it perhaps has less practical relevance. I mean, certainly patients will progress either through an MF phase or directly to AML, but when you're starting out treating them for PV or ET, all you can really do is focus on thrombotic risk, symptoms, spleen, things like that. I think that's perhaps the reason that we've tended not to do that. But it fortunately is still a small risk. It's still a very small risk for PV and ET, so which obviously have long life expectancies otherwise. So I think that's really the driver of that. If we had a drug or a strategy that could reverse, this process, certainly it would be more relevant.
So apart from possible implementation of prognostic factors in myelofibrosis, perhaps more than in ET and PV, for transformation to acute myeloid leukemia, there is not much else that we can do. We know that the JAK inhibitors do not prevent progression to acute myeloid leukemia. They don't enhance the risk either. They're just controlling the proliferation and inflammation, but they don't change a possibility of a change.